This is Brian Warmers recording a lecture from Medical Surgical Nursing on the topic of patients with hematological disorders. Here are your learning objectives for this. The first topic we're going to talk about is red blood cell disorders. And anemia is one of the first things that you might think of with this one. So anemia is lack of oxygen carrying capacity of the red blood cells. And so part of what we can think about would be sickle cell disease, which is shown over here, in which you get a misshapen cell, and then you get some clumping with that. Other things you can think about would be G6PD, which is fairly rare, autoimmune hemolytic anemia, which is fairly rare, vitamin deficiency, which is more common with your vitamin B12, iron deficiency, and folate. So you're more common to see those three things. So sickle cell disease, first and foremost, see if they've got a history of this, see if they've got family history of this, any previous crisis, if that's the case, what set them into crisis, what caused the resolution of this. Next one is physical assessment, clinical manifestations. So, how are they doing? Are they breathing all right? Are they circulating all right? Do they have lots of pain? Etc., etc. Psychosocial assessment, how are they functioning? Obviously, if they're coming into you in the clinic, they're probably not doing so well. But just see how this is affecting their life. Lab findings, we can do electrophoresis and looking for that hemoglobin S. We can also look at the hematocrit to see numbers. We can look at retics and just to see the counts and see how many cells your body's turning out. And we can look at the bilirubin to look at destruction numbers. Can do some imaging. It's not commonly done, but you can look at and see if there's any bone changes. So with the sickle cell disease, you can get anemia from this. It alters the shape of the cell. You don't get good carrying capacity then. Major interventions for this, manage pain. So it's giving opioids. And opioids, number one, for the pain. Number two, for the side effect of vasodilatation. Opening up the vasculature and allowing things to flow more readily through it. You do want to compare pain this time from previous episodes. You want to hydrate them a lot. You want to put some oxygen on them to try and increase any kind of capabilities that they have for carrying oxygen. And if they want to do some complementary therapies, that might work as well. Really want to try and prevent sepsis and, more importantly, multi-organ system damage because of those clotting. So we don't want any clots in the heart or in the kidneys or in the lungs. All those are bad things. So we might check for infection markers depending on if they look septic, and then start them on antibiotics. So we can do hand washing, always good hand washing, always good PPE, using that personal protection equipment. And then administer oxygen, which I would probably put higher underneath management of pain. And then, afterwards, prevention. What can we do to stop this from happening again? Looking at those signs and symptoms and how this progressed and how this got started. Anemia, so we can talk about like an iron deficiency anemia, vitamin B12, folic acid, and aplastic. So iron deficiency, of course, is we don't have enough iron in our diet. So it's either poor absorption, where they're eating enough but they can't absorb it. Otherwise, they're not intaking enough. So supplementation of iron usually fixes this. Vitamin B12, once again, it's very similar. It's deficiency. So it's either increasing that or finding a way to increase absorption. Vitamin B12 is usually absorbed through the gastric, through the stomach. So if people have had like a gastric bypass, then they might not be getting enough vitamin B12, and they might have to take supplementation through IM injection. Folic acid, once again, work on that for diet and malabsorption. And aplastic. Aplastic means that it's not being produced. So the big thing with this is we want to figure out why they're not being produced and then fix that cause. The other thing, it could be a cause of your spleen as well. So maybe the RBCs are actually being made, but maybe they're getting all destroyed by the spleen. And so you might have to take out the spleen as well. Excessive red blood cells, probably the one that I've heard the most would be polycythemia vera. and that's just production of too many, so it causes thickening in that blood, causes hypertension, can cause hypoxia because you're not oxygenating all those cells well. So this leads into more sludge, strokes, and issues like that because your blood is getting too thick. So treatment, hydration, so trying to expand it and thin it out with saline. Apheresis will pull some of those cells off, and just trying to promote good venous return to back to the heart. Hereditary hemochromatosis is excess deposits of iron due to a gene mutation. I haven't really seen this much, but it is out there. Myelodysplastic syndrome, so this can be a precursor to different cancers, but this can also cause anemia, thrombocytopenia, and neutropenia. So this can be as a side effect of drug therapy, or sometimes we just don't know what causes it. Treatment-wise, give drugs, such as your erythropoietin, to try and stimulate those agents. We can give blood transfusions, and sometimes that will help. White blood cells, so we can talk about leukemia, that's a major one. So it's uncontrolled production of WBCs, but the bad thing about that then is that it tends to drop your other lines, so you tend to get anemia because you're not making red blood cells, and you tend to get thrombocytopenia because you're not making platelets. 4 major types, so whether it's acute or chronic, and whether it's lymphocytic or myelogenic. So risk factors for this would be radiation exposure, illnesses, infection, bleeding episodes, or weakness and fatigue, and having issues related to that. So physical assessment. So basically we're going to see that they've got some anemia. We're going to see that they might have infections because you're kicking out a lot of the white blood cells, but they're usually not made in a correct manner, and so these blood cells are not doing their job as well as they should. And so you might see infection with this. You can see skin changes. They're going to get cold and a little change in pallor. They'll get pale. You can see some intestinal changes from bleeding and fatigue. You can see some CNS changes due to the hypoxia, which may include headaches, seizures, and coma. You can also see do a psychosocial assessment and looking at how this is affecting their life. We can definitely do labs, and CBC is probably your biggest bet because then you're going to look at your H&H, your platelets, and your WBCs. We can also look at clotting factors, and we can look at your bone marrow biopsy to try and tell us what cells are being kicked out of the marrow. So interventions protect them from infection. So this can either be auto-contamination, where they contaminate themselves from a different source on their body, or cross-contamination, where we give it to them or another person gives them an infection. Drug therapy, so 3 different stages. We're going to try and induce them and put them into a remission. This can be used with chemotherapy or radiation, usually chemotherapy. But the bad thing is that there tends to be side effects with that. Consolidation, it's done to try and promote a cure, and at this point in time, their counts are dropped down, and so we might do like a stem cell transplant, and then we're hoping that their body comes back and they're able to go into this next step, which is maintenance. So they're in homeostasis. However, we're hoping that those cells are not coming back. Since they have some platelet problems, they might have bleeding, so we got to minimize injury. The anemias that they can get with that, we want to conserve their energy. And then when they go home, we want to make sure that we do good home care instruction. We can talk about malignant lymphomas. So this is abnormal growth of the tumors in that lymphatic tissue. So we can talk about non-Hodgkin's and Hodgkin's. The biggest difference I want you to be aware of is that Hodgkin's lymphoma starts in a single node and it's got Reed-Sternberg cells, versus the non-Hodgkin's, which does not start in a single node, does not have the Reed-Sternberg cells, and honestly tends to be a little bit more widespread and harder to treat. Rates for the Hodgkin's lymphoma are really pretty good. It's above 90% for curing. Non-Hodgkin's, it's not quite as well. We can also talk about multiple myeloma, looking at those overgrown B lymphocytes. And then we can also talk about how you get excess of cytokines, which lead to cancer cell growth and bone destruction with that. So with Hodgkin's, like I said, this is more common, and commonly this will present as large painless lymph nodes. It usually doesn't hurt them, but it's just kind of a big bump. Tends to be symptomless. So to diagnose it, we're looking at CBCs, electrolytes, kidney and liver function, ESRs, bone marrow aspirations, and CT and PET scans. Treatment, so like I said, either radiation or chemotherapy at that site. And then, of course, trying to minimize those side effects. Non-Hodgkin's, very similar presentation. But you're really trying to figure out is where this starts, and then you're going to have to classify it as either a T cell or a B cell. These tend to be more aggressive, tend to spread more, and have worse outcomes. Once again, treatment with chemotherapy, radiation, and then once they go into remission, you can do like a stem cell transplant. Multiple myeloma, so these can be asymptomatic, but you might notice that they're fatigued, they've got anemia, they've got bone pain, and those type of things. So diagnostic-wise, so we can look at those within the bone marrow, we can also look at the protein in the serum or urine, and then we can also look at the osteolytic bone lesions. Staging and prognosis is based off those different lab values and interventions for this. So we're going to give some proteasome inhibitors. We're also going to give immunomodulating drugs. We're going to manage the side effects that they have of those treatments, manage the pain, and then treat any bone disease. Coagulation disorders. So when you talk about platelet disorders, so this can either be autoimmune or idiopathic thrombocytopenia purpura. So this is you produce enough, but for some reason you're destroying them. Oftentimes we see this after like an infection and your body just gets revved up, and it will coat the antibody and makes an antibody on those platelets, and then your body destroys the platelets. Otherwise it can be TTP, and this is when platelets will clump together in some areas of your body and leaving you without in other areas of your body. We can also have clotting factor disorders. So hemophilia is probably the number one thing that you've heard of before. And basically there's two major types. You've got one based on factor 8, which is type A, and one based on factor 9, which is type B. This tends to be, it's an inability to form a stable fibrin clot. It's not like if they get a wound, then they're bleeding at a faster rate. It's not that they spontaneously have all these wounds and they start bleeding like crazy. It's when they get a cut, then they have a hard time stopping. So heparin-induced thrombocytopenia is our next topic, and this is a drop in platelets following heparin therapy. We don't see this as much anymore because we're really trying to limit the amount of heparin that we use. We always used to heparin lock IVs and stuff like that, and now we're finding out we can use saline instead, and so we're having less side effects like this. But we feel that this is an immune-mediated response of the immunoglobulins based on that heparin, and that's destroying platelets. Just to reward you guys for listening to this power presentation, please do not share this information with other people that may not have been as diligent as you are to listen to this. But on this exam, there might be a question in regards to what my brother's name, and his name is Bryce, B-R-Y-C-E, and this is just to reward you for making sure that you're doing what you're supposed to be doing. So please do not share this with other students who may not be as scholarly as you, but you deserve a reward for going through this and reviewing it. All right, this concludes this presentation. If you have any further questions, please talk to your professor.